Alright, so we're going to do chapter 23 and 24 today. They're pretty short and sweet, kind of hard to beat chapters. So we'll do chapter 23 first. We'll take a break. I know that when I sit in a class like this all the time, every class, that it can get kind of boring. And I don't always learn the best because you kind of zone out. So for chapter 24, we're going to do a little bit of group work today. Sorry, not sorry, but it's just a bunch of collaboration to talk about things that you do or do not know with your colleagues, kind of get in the mindset of EMS. We'll do a quick case study preparation with your group, then we'll do lecture, and then we'll redo the groups to see if you learned anything different and how you would approach that same patient that your group has. Does that make sense? Do you guys have any questions or anything you want to talk about before class or saw? I don't want to take time from learning in the classroom from what you see either. So before we get into things, I have any questions? Saw something weird? Nothing? Okay. And then at the end of class, there is a little Jeopardy just as a review. I thought it'd be a little bit more interesting than me just asking questions the whole time. So if we have time for that, we'll do it. But anyways, so we're going to start with chapter 23, which is allergic reactions. So when we have an allergic reaction, there's a response to an allergen. The allergen is the insult to the body. The actual allergic reaction is your immune response handling that allergen or that insult where it feels your immune system needs to take place. Typically, with allergic reactions, it's an IgE modulated response. The immune system and how it handles allergens is very, very complex. Your book talks very minimal about it. So if IgE and all that doesn't make sense, just kind of have the general picture that you have an allergen, there's some type of immune cell that's going to recognize it. It's going to release these antibodies and mast cells. It's going to try to bind to that allergen. And as it does so, you're going to have a histamine and anti-inflammatory response. That anti-inflammatory response is one of the key things that makes an allergic reaction different from an allergic reaction that leads to anaphylaxis. Because whenever we have inflammation, it increases our capillaries to leak. So you start leaking fluid. That's where all of the white blood cells want to get into. That's how it's trying to flush that allergen or toxin out. But as it leaks, you're losing that fluid in your intravascular space. So the inflammation part is huge, and the histamine release is huge when we talk about allergic reactions all the way to anaphylaxis. Common causes of allergic reactions: bees, wasps, yellow jackets, wide range of foods, plants, medications, penicillins especially are on there. And we think of those common, but also it could be chemicals, soaps, makeups, detergents. A lot of times we think things in the air, but it could be things that we're exposed to daily as well. I've even had we had a little girl that got bit by a rattlesnake this summer that we flew out. She actually went in the anaphylaxis from a snake bite. She got bit by a rattlesnake, and even that triggered something in her body to go to full-blown anaphylaxis. And we ended up having to tube her. So a variety of things can cause really bad reactions. And then for EMS and healthcare professionals, it talks about latex particularly. There's all kinds of different substances or different tools that we have in healthcare that actually have latex. One of the most common ones, have you guys seen a Foley catheter? It goes into the urethra and it drains into a little bag. So it's this rubber tube we stick in our urethra into your bladder and it drains into this bag. A lot of times that is latex. The interesting part with a latex allergy, just like some of these other ones, is that you could need repeated exposure before your body has enough antibodies to modulate that anti-inflammatory response and that inflammation in your body. So with repeated exposure, you can eventually develop an allergen because your body's immune system has finally built enough recognition to start that kind of immune response cascade. Make sense? Most allergic reactions you're just going to know about. Poison oak, poison ivy doesn't affect everyone, but you're probably going to get a rash. Other times it is like the latex that it's going to take repeated exposure. So just because you have a patient that says, oh, well, I've been taking this medication for years, doesn't mean that eventually they're not going to have an allergic reaction to it. Any questions on this? And most of the IgE, if you're more interested in that stuff, is this kind of stuff. So the big terms, kind of test terms that you might see, one of them is urticaria. Some people say urticaria. That's just hives. That's the medical term for hives, and that's on the left. That's where you see kind of those red blisters or mosquito bites on someone's skin. That's urticaria or urticaria, depending on who you talk to. That's just the technical term for hives. So if you see patient has urticaria on their skin, what is it? It's just hives. And then we also have angioedema. Angioedema, as we all have heard on like some commercial on TV, is swelling of the face, tongue, or mouth. And angioedema can be a gradual process as well. So this one kind of has a time picture of it where you probably notice some swelling for whatever reason is unknown for this picture. Eventually it got so bad that he ends up tubed for airway protection. So I know the pictures in the beginning are all kind of with his lips, but you can kind of see where his tongue starts to swell. And then if that starts to block the airway or your airway starts to swell in the back, so it's also important to do an assessment, like looking in their throat. That's where you end up tubing them before they lose the airway. And then you can see the difference in how bad that angioedema was. But angioedema is swelling of the face, neck, throat. If you're concerned about any kind of angioedema, your reassessments will always be your ABCs, airway, breathing, circulation. It's not just, oh, he has a fat lip. It's, hey, can you say ah? Can you open for me? Because you'll slowly notice that it'll start to close. And that's not a good thing. And this could be like Q1 minute, Q2 minute, Q5 minute reassessments of just their airway alone. Because this process can also be very rapid as well. Not a gradual, but that's just the example picture I found. So urticaria is hives, angioedema, swelling of all this, we're more concerned with airway. Signs and symptoms are important. Most of the time, I kind of rearranged how your book goes. You're doing your ABCs, so we're focusing on respiratory first because it's the first thing that we're gonna want to intervene with rather than the skin. They might have tightness in the throat or chest, cough. That's part of increased mucus production and trying to clear that airway. They might breathe a little bit more, have labored or noisy breathing, hoarseness, muffled voice, or actually no voice, where they can't even talk. All of those come from that increased swelling, increased mucus production. It's your body trying to fight something, but it's really hurting itself in the process as well. The skin, pretty straightforward, warm, flush, swelling, hives. There's not much you're going to be worried about in the skin short term. It's just that, oh, you had allergic reaction. Is it affecting your respiratory? Should be your next thought. So ABCs always, but watch how and where it spreads from their skin. Because if you have something that starts on the hand and you notice it going up the arm, it's going closer to your airway. So just keep doing your respiratory checks, your ABCs. Others, same thing, your body's fighting itself, it's fighting the allergen, your heart rate's gonna go up, your BP actually might go down. Sorry, that's supposed to say low BP. And then all of those mucous membranes with that allergic reaction are trying to flush out that allergen. That's where the tearing, redness, the mucus in the lungs comes from. And then if they're not getting enough oxygen, they can't breathe very well, they also might be altered. And then there is also a reaction that occurs in your gut as well. where you can have nausea and vomiting. The impending sense of doom is kind of an interesting thing when you actually do get to see it. We do deal with a lot of difficult patients in healthcare where you're like, oh, they're just really being jerks and they don't want to listen to what I'm saying. But someone that actually has an impending sense of doom can come off that way because it's like they know that they're on their way to dying and it's just their way of having that anxiety and of like, oh my gosh. It'd be like slowly closing your airway off. You'd be like, I need help. And you'd probably be grasping at anything you can to get it. So just because someone might seem like a jerk right away, please do not ever rule out impending sense of doom that maybe they do have something going off or going on that I need to help them with. It's very hard to describe, but once you see it and then see how the patient gets worse, it's a very hard thing to watch. Okay, I have some gripes about anaphylaxis. First off, anaphylaxis is a quick, fast process. Typically within a couple minutes to 30 minutes, if not always under an hour. Someone comes into the ER because they got stung by a bee 10 hours ago, and they think they're in anaphylaxis. They're not in anaphylaxis. Anaphylaxis is a very quick process. It's very fast. That's like the peanut allergy you hear about most often. Their throat closes right away and the school nurse doesn't even get there. Anaphylaxis is a quick process. Don't be that person that shows up, oh my God, I got stuck by a bee 8 hours ago and I'm going into anaphylaxis. No, you're not. Sorry, it's not how that works. Time is it. You could get stung by a bee 5 times and that 5th time triggers it, but your airway is going to close faster than the other ones. It is a quick process. To be anaphylaxis, you have to have signs and symptoms that we've already talked about, but there has to be some sort of respiratory symptom that is extreme and/or signs of shock. Shock is the key here in respiratory because we're worried about airway closing rapidly. And then when they go into shock, when all of those capillaries start leaking and has that hyper exaggerated response to that allergen, it's going to third space. I mean, it's going to put all the fluid in their vasculature out in their body. So it's going to increase swelling and then it's going to tank their BP. So we always do ABC and EPI. So we're going to do airway, breathing, circulation, and EPI. If possible, it's always good to try to say, hey, do you have what's going on? Well, I have a peanut allergy. Okay, let's get you away from that exposure. Oh, well, I'm taking an ACE inhibitor. I take lisinopril. Okay, like that way, when you call the ER, that they have a better way of how to treat the underlying cause, not just make the patient better if they can. But sitting there while someone's not breathing and then like, did you eat some peanuts today? Are you okay? And they're like, don't do that. ABCs and EPI first. Before we go into EPI, because there's some important things about EPI, I think it's important to do a quick review. This is a little different, might be a little bit more like nursing centered, but I know that your books has 5 rights. I was taught with 6. But before you give any drug, you should always check it at least 3 times. And your checks are, is it the right patient? Especially if you're in the emergency room, you don't just got like one patient in the back of the bus and you're like, okay, I know you're the one I'm treating. But like you have all these different patients in a mass casualty, you're in the ER, make sure you have the right patient. You have the right drug. And it's not just the right drug and dose, but it's the right concentration of that. We're going to talk more about epi and concentration here in a little bit. You're going to make sure you're giving it by the right route. Epi, you can give in the muscle, you can give in an IV, you can give in an IO, but other drugs are purely IV. They purely IM, purely IV, purely sub-Q. So not all drugs are adaptable to every route out there. And you can really hurt someone if you're not giving all of those correctly. You have to give it at the right time. This is more nursing thing where we have things that are like ordered, but also if someone's in anaphylaxis, you're going to give it very soon. And then you should always be documenting all of the medication administration that you did correctly. So that's where you literally write down, like in Waters, our charting system for EMS, it lets you fill in the concentration, the drug you gave, how you gave it, the time you gave it, because those are all important. When we talk about medication basics, I feel like meds just get thrown at people. More people will die of medication errors in hospitals than breast cancer, lung cancer, car crashes, and like HIV and AIDS complications alone every year. So you take all of those, more people die of medication errors than all of that combined. So medications aren't like no joke. And everyone studies them a little differently. And we're in a high intensity, high stress environment sometimes with some of these patients that we're treating. So the way my mind works is, yes, I'm going to do all my medication administration verifications. I might have my partner look at the medication with me. We do this even like when things are really bad in flight. We're out in the middle of nowhere. It's freaking dark and it's cold right now. In the ER, you like scan your little med. The computer's like, yeah, good to go. But never be afraid of like, hey, Bridger, you see how much epi this is? And he's like, yep. And if someone ever comes to you with a medication and they're like, hey, can you verify this? It's not like, oh, yep, looks good. When you do meds in nursing, they teach a timeout. You are focused solely on that medication. It is like you're the child that was just born. Everyone focuses on the child, on the baby. Medications can go very bad, and not all of them have reversals. So someone's like, hey, I think I want to give this medication. I'm like, okay, what is it? What is the name? What classification of drug is it? If you get really good at your drug classes, then you'll know the things that it can cause, right? The side effects, essentially. Why was it needed or ordered for this patient? When you give a drug, typically everything's protocol driven, right? Cardiac arrest, you give this epi. You do your CPR, you do epi. But I can give epi for an asthma patient. I can give racemic epi through a nebulizer. And then say you have glucagon, right? You get to the ER, you have someone with a food bolus in their throat. And the doctor's like, I want to give glucagon. And you're like, his blood sugar's not low. He's not a diabetic. Are you going to give the glucagon? If you don't know why? Yeah, don't give it. So you say, hey, doctor, I see you ordered glucagon for the patient with the food bolus stuck. May I ask just why before I give it? They're going to say, well, glucagon relaxes your smooth muscles. So it's going to drop that food bolus hopefully into their stomach and help their body clear it. So just because it's not your typical use of a drug doesn't mean it can't be used for something else. That is why is it needed or ordered for this specific patient. And then I'm thinking, kind of like with your quiz, I didn't really look at the quiz. I'm going to evaluate them before I give it, while they're getting it, and after they get it. If I know I'm going to give a medication that's going to drop their blood pressure, I'm going to take a blood pressure first. Because then if it's too low, I'm not going to give it. If it's fine and I give it, I'm going to check their blood pressure after. So it's not just, I'm going to look at what happens after. What does your patient look like before you give it? Because you do not want to make them worse. And then, is there a reversal for this? Or no? Because there's very limited reversal for things out there, but the odds of it that you're going to carry it on a truck and then have it in the middle of nowhere, hours from a hospital for EMS, is probably very low. But when we think medications, they're very important. They can do a lot of help, but also they're a band-aid, right? They're not any kind of definitive care. They're just helping fix something short-term. But you should always be doing your 6 rights or 5 rights in your book of medication administration and kind of have a strong understanding and confidence, maybe not in knowing your meds right away, but knowing how to address them and how to learn to be better with your medications. This might be more like my nursing soapbox, but I've seen really bad things either way, EMS or nursing. Alrighty, when we talk about epi, scan 23-2 is what it's listed as on page 661. This is just kind of an example from the last slide. The name is epi, adrenaline, EpiPen Junior, Acuv. It's a beta and alpha adrenergic. It's catecholamine. So beta and alpha don't mean much to you. That's okay. It's just the type of receptors on your cell that the epi is affecting. Epinephrine has a chronotropic and inotropic effect. Short term, epi is going to increase your heart rate and it's going to increase your contractility. It's going to try to bump your cardiac output. As an anaphylaxis reaction in a distributive shock, which is what anaphylaxis is, when all of that fluid's leaking out, we need to help fill the tank, but we also need help to make sure that that tank's actually squeezing at full power. So we have cardiac output. When we have good cardiac output, you give them oxygen, do everything else good, you're going to have good perfusion. And then things like your brain and your heart and other important things aren't going to start dying off. We're going to give the type of epi that we're talking about here for anaphylaxis or asthma patients. Why do you guys think I didn't put cardiac epi on here? We can give epi for cardiac stuff. But why don't you think I put cardiac epi on here? Yeah. Yep. But there's also different concentrations of epi. When we're talking about the anaphylaxis chapter, it's a different concentration, and we'll go over those next. I'm going to evaluate their airway, heart rate, BP, swelling, their overall perfusion. And then there is a drug that can kind of block epi, but once you give epi, you've just given epi. There's not much you can do after that. Our dosing is 0.3 milligrams for adults. Children under 30 kilograms, it's 0.15. So if you have a bigger kid, you can give the 0.3. But your book lists this height or this weight specifically as the cutoff to differentiate between peds and when you can give a higher dose to them. Any questions on this slide? When we talk epi, there are 3 main concentrations of epi that you're going to see. For an EMT basic, this might not mean much to you, but I still think it's important to understand because if it does get to the point where you can help draw up anything to help your partner, or you see different things out there, epi is not just epi. There's different concentrations for different reasons. A lot of times you won't hear 1 in 1,000, 1 in 10,000. You'll hear 1 to 1, 1 to 10, or 1 to 100. But technically it's 1 to 1,000, 1 to 10,000, and 1 to 100,000. The 1 to 1 epi is the most concentrated. The 1 to 1 epi is what you're going to give for your anaphylaxis and severe asthma patients. That's your 0.3 milligrams or your 0.15 milligrams. This concentration is so high, it can only be given IM in the muscle. If you give 1 to 1 epi IV, in poor terms, you blow their heart out, they end up in the ICU and they probably die. And your 0.3 milligrams it's typically 1 milligram in 1 milliliter. that much of 1-to-1 epi, so on a 0.3 vial, in the IV can kill someone. Because you overstimulate, it's way too concentrated. So that one is IM only. That's the one we're talking about for anaphylaxis. Your 1 to 10, 1 to 10,000 is your cardiac epi. So that's what you're going to see your paramedics giving in an arrest. I always think of 1 to 10. If you give a rock 10 things of epi, you're going to get a pulse back. So, and then the 1 to 10,000, you're typically going to see coupled with like a lidocaine or a numbing solution, where if a doc has to go do stitches somewhere where it might be a little bit more bloody, it'll help constrict those blood vessels so they don't bleed as much. So then he can sew them up better. Sometimes they'll put it in the nose to stop nosebleeds just to help constrict those vessels. You can take your 1-to-1, or your paramedic can take the 1-to-1 and make a cardiac or make a drip, but your 1-to-1 will then have to be diluted. You're never just going to give someone straight 1-to-1 through an IV or an IO. So when it comes to the book, what we're learning about, when it's in the EpiPen auto-injector, 1-to-1, IM only. When you have someone that has their automatic like EpiPen at home, please always make sure that you know which side goes to the patient and which side gets pushed. Because there are many times where someone's like, I'm going to save this life, and they inject their thumb. So usually it'll say like to thigh, to patient, like to skin, I even saw once. And then you just stick it in their thigh and push. You can give it in the arm. It is an IM injection, but there's typically more mass and it'll be absorbed faster in the thigh. Especially with little kiddos that are really small, you want more absorbed to obviously have a quicker effect, but you can like go through their bone, then you have to like pull out a little bit, and that's just uncomfortable. You don't really know how far you are into the muscle at that point, but the thigh is the best. Outer thigh, and they inject it. Cool. Do you have a syringe and all? Do you have a syringe? Does it make sense about epi? I feel like they're very little things. I don't know how your tests go, but when I got tested on epi, every time it's like, which epi are you gonna give? And you're like, oh shit, multiple epis out there. Okay, that's the end of that. Everything else is pretty self-explanatory in your book. So, any questions? Okay. So, if you guys want to look at this eventually, adrenaline, right? Another name for epi. It says on here 1 to 1,000. When you draw up your epi, this is the ER way, you just kind of punch through this. Screw this on. This is your syringe. We're going to do an adult dose, which is 0.3. So it's going to look about that much. That will kill someone through an IV very quickly. That much. That's it. When the lid is on one of these medication vials, under it is technically sterile. So when you pop the lid, stuck on there. Oh yeah. Get me up. Thank you. I don't want to fling it across the room, minding my manners. So you flip this off. This technically is sterile. For some reason, something touches it, try to wipe it, but don't be like, where's my alcohol pad to clean this? While your patient's like, like just draw it up. The odds of them having an infection from an IM injection is extremely low. I have seen someone do that. That's why. Like our patient's airway was literally going, and me and the doctor are getting the crike kit ready, and we're like, "Where's the epi?" And they're like, I can't find an alcohol pad. And I'm like, oh my gosh, it's okay. But
read through your little
yes,
thing for this. One of the things you're going to be tested on. I believe it says you have to
yep.
spot. 2 separate pads to do a long drawn out process.
Some people too, like will drop the air first, because then when you go to at a direct angle, and then you flip it. And then something important with these is the bevel of the needle. Make sure it's below in your actual solution. If you're like way up here, I'm just pulling air out. But some people will inject air in first, and then it'll help the syringe fill. When you guys are using these very, very small syringes, the slower you go, the less likely you're going to have a massive air bubble. Little bubbles in there, just fine. Your body absorbs those, it's not going to hurt someone. And then if you're like, I can't get the air bubble out of the top, and you're like freaking out and you're like flicking this thing, just drop a little extra, right? So I'm at 0.35, and then you just waste a little bit of it. 0.3. You wipe it, pinch it, put the needle in, inject it, take it out. Pretty simple. This is an IM needle. You can also grab a bigger needle to draw it up quicker, but when you're drawing up this much, it doesn't take long through a smaller needle. And remember, the bigger the number, the smaller the needle. So an 18 is bigger than a 25. That's it. And then you dispose of your sharps. You don't recap needles. Said no one ever in nursing. My nursing instructor did. I know, it's like magic. Try to make it fun. It's really boring. Any questions? Great. Ready for group work. I apologize. Yeah. All right, let's do this. Okay, we're going to do things a little different tonight. See if we learn a little bit better, get us out of just sitting here staring at me and eating candy. So this is chapter 24. It's the infectious disease and sepsis. Control. Okay. This slide is important. We're going to split up into 3 groups. If you're online, do your own thing. That's up to you at home. We're going to get into 3 groups. Each of you will have a patient from the next slide. In your little groups, so the call information is what I'm going to give you. I want you guys to talk in your groups about things that you might want to prepare or that you're thinking about. I want you to give me a primary diagnosis for the patient. So like imagine you're on the, beep, beep, so excited, you're on your way to your call. You're going to say, I really think it's this first, right? Like you go to a chest pain, your partner's like, I bet it's a STEMI. And they're like, no, it's asthma, right? Primary diagnosis. And then because you don't know yet, you're not with the patient, I want 2 more diagnoses of what it could be. So things that you're thinking about that are a little different, pre-gaming. If the ABCs are not good, what are some things that you can anticipate that you're going to do or that your paramedic might do? And then you're going to talk about any additional considerations, thoughts, what are you thinking? What do you not know? Do you know? And then we're going to do the lecture. And then we're going to talk about your case studies at the end. So it's a little bit different. It's very open. But I want to bring more teamwork, more pulling different ideas from different chapters and lectures into what you're actually going to be doing when you're on a rig. Does that sound fair? So I'll pull this back up. Do you want me to count like 1, 2, 3? Do you want to like find your groups?
Austin, Bridger, Kelton, Captain, Lena, Quiet.
Cool. You guys want to space out for a little bit? Sorry, forced fun at 9 p.m. Yeah, it's on the next slide.
Okay. Sure you get the information you need.
Yeah, I can switch it back after. We'll give it like 5-10 minutes unless you all stare at me sooner. Yeah. Oh. I wore my good jeans today for doing this with your prompt. So these are your prompts. We'll say you're group 1. Your call is an 89-year-old male, conscious breathing. He's had diarrhea for 3 days, some blood in it, and he was recently on antibiotics for pneumonia. Middle group, you guys are group 2. 16-year-old male, conscious breathing, but he has an altered mental status and a high fever for 7 days. Group 3, your call is a 6-month-old female, breathing, trouble breathing and conscious, and the mother reports that the patient's lips are turning blue. So that's your information. That's your call out. That's all you get. That's actually quite a bit of information. Sometimes it's just like bloody diarrhea. You get an address. Awesome. So do you guys have this information? Yeah? Good? Yeah? All right. This is what I want you guys. Yeah. You need more space. If you don't want to like an Uno, don't want to look at all my cards. This is what you guys are talking about with your group like you're on a call. Okay. I can move slides if you need me to. Yes. It's up to you guys. You're on your bus. Yep. Yep. You're good.
Think about what you can do, what you can't do.
Hmm? I know. They just left us cups.
Go into our split. I got a big
Hmm.
half an hour push up and pulls all the way over. On the next one.
Oh.
It came down right.
Oh.
I go walking in there. They've got them all wrapped up.
How's your day going?
It's like having casualties already. Yeah. They didn't realize the thing didn't stay up, and I was like, oh, it's like a real world thing. That was strange.
You're like, this,
Yeah.
it's real life. Guys, it's very broad. It's whatever you want to make it to be. There are no right or wrong answers. How you guys doing? Very broad. There's like no right or wrong answers. Just imagine this is your life one day. That whole textbook goes with you. Sadly. So, you guys need anything? Okay. You can literally make up whatever you want. You could say he has food poisoning because he has diarrhea. I don't care. He had some bad Subway. I don't know.
This one unit, but work together on coming up with a way, not all three of you working on an idea, scheme thing.
I remember in nursing our longest days, we would take our test and then to help with stuff like this, like real world problem solving. Then we had to take the whole test in our groups. But then it was nice because then if you got a better grade, like if your group got a B or an A on the test, you got points back for your own test. You know what you're thinking? Is he a DNR? That's horrible to say, huh? Like, is he 89? Is he a DNR? We rolled up once in I think it was Buffalo, and we pick up this like 99-year-old with pneumonia. She's fine. She's on like 2 years of oxygen. I'm getting reported like she a DNR, I'm like DNI. This other nurse pitches in. She's like, "Oh, she's getting life flighted." I was like, "She's 99 years old." I was like, "What does the patient want if things go bad?" Oh, God. That is my goals in life. Okay, 5 more minutes. What's up? 5 more minutes. Alrighty, so now we'll go through lecture. Then you'll go back to your case studies, and then we can do a little Jeopardy at the end. But the goal of that is to take what you know from your book and think, wow, I'm actually going to be treating patients one day. How am I going to do that? What do I know? How do I work with my partner? We can't stay in a classroom mind because outside is not a classroom. That's where you learn and grow and you make your mistakes. All right, so basic terminology: infectious disease goes in your body, does bad things. In short, communicable disease is spread from person to person. So things like HIV, AIDS, respiratory things like croup, hand, foot, and mouth disease, person to person. Bacteria, viruses, fungi, protozoa, and parasites are all things that can cause disease. Bacteria are living organisms. They have a nucleus. The viruses have a shell around them and they contain RNA or DNA. There's a difference in how they're treated. Then your fungi, protozoa, parasites, those are all having to have the host to typically live. Fungi is more of your yeast, your yeasty patients. Nothing super incredible there about your chapter. Table 24-1 gives you all of the things that the chapter talks about, kind of what to look for, what is it, signs and symptoms. When we condense diseases down, right, you hear pertussis, diphtheria, tuberculosis, HIV, bacteria, COVID, all these things, right? What is it, or what do I suspect is it? Is it a bacteria? Is it a virus? Is it a parasite? Is it yeast, fungus? What is the basic component of what's causing that disease, and what can it do to that person? Then you're like, oh, I have an idea of what it could be. You need to protect yourself first. We have like super medics and like super nurses out there that won't put any PPE on and go into dirty rooms, meaning the patient is highly contagious, or they go into a trauma with like no gloves or nothing. Protect yourself first. Put your gloves on at least. Plus, people are gross and there's poop everywhere and blood and gross things that I don't even want to say on Zoom. Put your gloves on, at least gloves. Protect yourself first, please. We had a nurse in trauma, patient like rolled, got ejected, had glass everywhere, and had like open cuts and everything. She had cuts on her hands. Then we're like, oh, patient tested HIV positive. But she was super nurse, so she ran in there and got blood from him and her cuts. So put your PP on, it's important. Just assume everyone is like the dirtiest person you've ever met, in my opinion. What signs and symptoms are present or not present? Recent travel gets missed frequently when we ask patients about what they might have been exposed to. The recent travel to a lot of times is like a key test question thing. So things like Ebola, malaria, kind of important to know where they come from. So if someone's like, yeah, I just traveled to Africa, you can kind of narrow down their symptoms to that specific disease that you might be tested on. And then how can I prevent it? How am I going to treat it? Are there any post-exposure actions that I need to do? I'm not here to talk about vaccines today. Like we're all Wyoming people, we're pretty chill. But sometimes they recommend getting a vaccine before. Sometimes they say you should be vaccinated after on things. Just know what your book says, what you get tested on. I'm not here to talk about vaccines. When I think more of post-exposure actions, I think more of people with bacterial meningitis because it is highly contagious. It requires full PPE. And if you're in close proximity with a patient like that for a while, you'll get you can go to your doctor or talk to whoever the doctor's on. They give you a single dose antibiotic. Typically it's clindamycin. You take that within 12 to 24 hours and you should be good to go. I've only had to do that once, and it was actually with flight because you're in a sardine can with a patient with bacterial meningitis and he is breathing everywhere. So that's what I think of more for like post-exposure actions. There is like the PrEP and whatnot for like HIV patients that you can get exposed to. and that's an antiviral medication. And then is there any other special considerations? So you basically take that table, filter it down to this to get to what do I think it is, how's it treated, how do I protect myself? But I'm not going to go over the whole table. Pretty straightforward. Any questions? All right, here's some like World War Z stuff. This is the common things that's listed in your textbook. I'm not going to go over everything that's in your textbook, but there's key words, key determinants, whether that be from a patient symptom or in a test question that might be able to lean you towards one of these versus the other. Chickenpox versus shingles. Someone that's had chickenpox can eventually develop shingles. Shingles is a linear rash and it's extremely painful. They have a rash like all over their body and it looks like hives. It's not shingles. Shingles is linear. It'll follow a line because it's following a nerve pathway. And that's part of the reason they become so painful. It'll start out kind of, red, swollen, kind of look like hives. It'll be that line, it'll be linear, and then it'll blister. Those blisters, when they're open and exposed, are actually contagious. Pregnant women especially should not be exposed to open shingles. Once they're crusted over, you're good to go because then the virus is trapped back down. The shingles is a linear rash that follows a nerve pathway. When it's blistered, when those blisters are open, they are technically contagious. Measles and mumps, your rash, Koplik spots. Hepatitis A, B, and E is what this book talks about. Hepatitis A is fecal to oral. So someone didn't wash their hands at the restaurant. Someone mishandled your produce at the store. It gives me flashbacks of something else. But fecal to oral route, and then it can eat contaminated poop is what it comes down to. That is hepatitis A. Awful. Apples. I don't know how else you want to remember it. Hepatitis E typically accompanies hepatitis B. You'll actually see them most likely together. Hepatitis B is contracted from bodily fluids. So that's where it talks about your IV drug users, unprotected sex, things of that nature. So whenever you think hepatitis, make sure you know the route that it's going is the most important part, especially for testing. Jaundice is the technical term for yellowing of the skin because hepatitis is going to affect your liver, your hepatic system. That's where yellowing of the skin comes from. HIV and AIDS, you can get Kaposi's sarcoma. Probably didn't say that right, but it's a type of skin cancer that can arise from it. That's your bodily fluids as well. Influenza, croup, those are all from respiratory droplets. Croup is your barking-like cough, is what it's described as. Pertussis is more of a inspiratory, I can't remember the word they use, it's not a bark. Whooping is how they describe pertussis. And then pneumonia, it's in your lungs, causes infection. A lot of times you'll see a virus knock down the immune system. So like in COVID in the ICU, a lot of people didn't actually die of COVID itself. They died of what we termed COVID pneumonia. So they got COVID, had their immune system, the respiratory system knocked down. It allowed a pneumonia to set in, and then people would actually die of the pneumonia, not necessarily of the COVID. Same thing can happen with influenza, croup for little kiddos, RSV. C. diff, Clostridium difficile, should be like automatic, like red flags in your mind. If you have not smelt it yet, you could probably walk in any room and house after and say, I think you got the C. diff. C. diff forms spores. It's a bacterial infection. Those spores are what keep it alive and very hard to kill because it has an outer coating that antibiotics essentially have to get through to kill the bacteria on the inside. If you have a C. diff patient, alcohol will not do anything to those spores. You have to use soap and water and bleach. So if you have a C. diff patient on your bus, you're going to wash your hands with soap and water and you're going to bleach the cot. Not just like the purple Sandy wipes, but bleach. In the hospital, people like full gown up for that because the spores will float in the air and then you can inhale them. That sounds really scary and it's really gross if you see C. diff patients. I feel really bad. But this typically doesn't happen in your normal healthy individual. The C. diff patients that you're going to see are you're extremely young and extremely old, people that have a suppressed immune response. They can be on something called protonics that kind of messes up with their good bacteria in their gut. And then antibiotics can actually kill the good bacteria in your gut and in your colon to where you might have C. diff living in you, but when you kill all that good bacteria, keeping the C. diff at bay, then that's where the C. diff comes in and causes an infection. So recent antibiotics, really old, really young, diarrhea for days, it has a certain smell. And the only way to test for it is to scoop some poop and send it to the lab. So, tuberculosis, that's your night sweats, your proximal cough at night. You need prolonged exposure to a tuberculosis patient to actually get it. The TB test is the one where you feel under the skin. In certain countries of the world, they actually have a vaccine, not for tuberculosis, but that it'll give a positive reading on their test, but they don't actually have tuberculosis. Tuberculosis in other countries is extremely like horrific to like watch. We had to like watch all these really bad videos, but it's an infection within your lungs that will eventually spread. They can have bloody, like, I mean, just blood like pouring out of them because of how bad their bacteria starts to like affect their lungs. That's tuberculosis. You need prolonged exposure. Meningitis can be viral or it can be bacterial. The bacterial is the one that is highly contagious, that you want to protect yourself from, that it could spread to you and it can spread very quickly. Signs and symptoms of meningitis, they're going to have a stiff neck, a high fever, they can be altered. With the meningeal irritation of meningitis, there's two different signs that you can test for that. If they're laying flat, it's like I'm flat on the bed. If I flex someone's neck, their knee will come up. And then if I flex someone's knee, their neck will come up. That's kind of the short version of it. And that's from such bad meningeal irritation in their spinal cord and brain that it's like a super taut rubber band. You'll pull one side and it moves the other. But stiff neck, high fever, altered mental status. Huh? Yep, they can have like a splitting headache with it. They can have photophobia, it's bothering their eyes. There's different ways to see if it's viral or bacterial. To officially diagnose a meningitis, they have to do a lumbar puncture. So it looks very simple, but they insert a needle into the spine and they drain fluid off and that fluid gets tested. Something else they can do is that you have the needle in a spine and there's this really long glass beacon that comes with it. Not all doctors use this beacon, but there's actually a pressure within your spinal column when they tap into the area they do for a lumbar puncture, where if they tap into it, connect that glass meter, fluid will shoot super high. And that is an indication of bacterial meningitis. It's that opening pressure that shoots up from all basically the waste products that the bacteria is producing. So bacterial meningitis worse than viral. You have to have a lumbar puncture. And then the meningitis can also cause other problems as well. So we flew a kiddo out. He was probably one of the sickest kiddos I've ever had. He had meningitis so bad for so long that it led to empyemas in his brain. You hear empyema, you think really bad things. He had giant pus-filled sacs in his brain. So it's going to affect your brain, your spinal column, and it can get worse. You have your STIs. Not really going to talk about those. You could read about them. Just know how they're transmitted. Chlamydia specifically has an incubation period that's a little bit longer. Someone can be asymptomatic, especially females can go 9 months with like no symptoms. So you have a lot of pelvic pain, discharge. Diseases carried by ticks. Lyme disease is the main one that your book talks about. And then MRSA and VRSA. So methicillin-resistant Staphylococcus aureus, vancomycin-resistant Staphylococcus aureus. The staph is the main bacteria, and it's highly resistant to these antibiotics, and it's very, very hard to kill. If you ever see like pre-op people cleaning the inside of someone's nose, most of the MRSA, if it is living on your body already, lives in your nose and in your armpits. So that's why they're trying to crack down on this really hard to treat type of bacteria. They'll actually clean your nose and sometimes your armpits in like pre-op places. In trauma, we clean their nose twice a day, every day for the first 7 days they were admitted. Because MRSA is an opportunistic infection, kind of like C. diff. MRSA has to wait for an opening, such as a cut, could be an open femur fracture, and then it sees the opportunity to get in and cause havoc. But these are extremely hard organisms to treat. And because they're bacteria, they get treated with antibiotics. Viruses do not get treated with antibiotics. They get treated with antivirals. So if someone goes, I'm on antibiotics for influenza, is it the flu or pneumonia? Right? We'll just make that clear. It's one of my pet peeves. Antibiotics kill bacteria, good and bad, in your body. If it's something viral, it's an antiviral medication. They work different because those bacteria have the nuclei. They have their own little system. Viruses have that shell. The antibiotics aren't going to do anything to it. All right, sepsis is like this much in your book. Maybe it's my nursing taking over. Sepsis is like this much in the world. It's huge. So I pulled this from the CDC and one of my like critical care resources, but 1/3 of people who die in a hospital have had sepsis at some point in their stay. Most cases, before the patient goes to the hospital, yet nearly 1/4 to 1/3 of all people with sepsis have had a healthcare visit within the week prior. Hospitals are dirty places. We can clean them all we want, but a lot of sick people come in, they bring things, you get exposed to it. Sepsis. Most people with sepsis have at least one underlying medical condition, whether that be diabetes, asthma, COPD. They have already some sort of a weakened body system, right? They're fighting something else already. And then we think about this. Sepsis is bad. It affects all these people. There's so many different ways you can get it. Healthcare professionals can cause sepsis, right? And that's something to think about for the patient and treating them. But also, an average cost, if someone's going in just for sepsis alone, in Wyoming is estimated at 30 to 50 grand per stay. So the cost of sepsis, with how frequent it is, how much it occurs, how much is required to treat these patients, is in the billions each year throughout this country. So not only does it impact our patients, but it does have a very costly effect. So if we can do things to prevent it, treat it early, that's even better. Sepsis is huge. And your book talks this much about it. And these patients are some of the sickest and most common patients that you're going to see. It might not be picking them up right away, but it might be when you transfer them out later. Because also we have to think about, you could bring a trauma patient in who has AFib, who has heart failure, who's had a prior STEMI, who has COPD, who's on oxygen. So you're dealing with all their underlying conditions and their trauma, and now they're septic. It's like one thing layering on top of another. So the more we can do to prevent this, to recognize it early, is also key. I don't think Douglas does it since I've been there, but in larger hospitals, in certain hospitals that we transfer to for flight, you can actually call a sepsis alert, because one of the keys to treating sepsis is antibiotics. And as nurses, some places you're actually legally bound to make sure that you administer antibiotics within a certain time frame. But where we go more into septic shock a distributive shock, it's important to understand kind of the progression of what we're looking at and the different terminology. So before we get to sepsis, we have SIRS, Systemic Inflammatory Response Syndrome. Again, we've talked about when we have inflammation in the body, our capillaries are all leaking, sending white blood cells, it's flushing things out. As our capillaries leak, we lose intravascular volume. Also, with any type of inflammation, that temp around there is going to go up. And then if there's more inflammation throughout the body, temp's going to go up. So with SIRS, you're going to see fever, tachycardia or a fast heart rate, tachypnea or a fast respiratory rate, and you're going to see their white blood cells on their labs go up. The heart rate is trying to compensate for that intravascular volume depletion. It's trying to help increase perfusion. The tachypnea is also trying to move more oxygen to get rid of more carbon dioxide. And then your white blood cells is that immune response as well, as saying, hey, we have something we really need to fight here. That's SIRS. If something bad happens, that's where you want to try to catch it at. To say someone is actually septic, typically it's only 2 of your SIRS criteria, and then you have to have a known or suspected infection. And that infection can come from anywhere. Typically, in your hospitalized patients, it's going to come from a bed sore. Typically, bed sores are on the bony prominences, especially right here on their tailbone. And then you have the hips, shoulder blades. And guys, patients that can't move in bed should at least be up or turned every 2 hours. Doesn't always happen. And sometimes that's not always the nurse's choice either. The pressure sores typically here, that's a big cause of infection. The GI and GU tract, things like a Foley catheter, so that drainage bag, that bacteria can crawl up that tube and into your bladder essentially if you don't keep the tube clean and off the floor. And then really anything that opens your skin, fractures, cuts, diabetic foot ulcers, any way that bacteria can get in there, because sepsis is your body's overwhelming response to a systemic infection. So you could have someone that has had a really bad cut on their leg, whether they don't clean it, didn't seek help to close it up, allowed more bacteria to get in. If it's just in that localized site, it's not septic. It becomes septic when it hits the bloodstream and travels everywhere else. And that's where you get that overwhelming response, because now there's bacteria everywhere and your body's trying to fight it. That can help clear up sepsis a little bit. Then we progress into severe sepsis. We have signs of organ dysfunction. We have gone into a condition where our lactic acid bumps up because we're having to work in an anaerobic way. We're losing oxygen, we're losing perfusion, so our lactic acid's going to build up. They can become altered depending on what organism's actually causing the sepsis. It actually might cross the blood-brain barrier, and that's where it's coming from. Or certain things like E. coli can also release toxins that can affect your blood-brain barrier. So that's where part of the altered mental status comes from. And if that's not the case, they become hypotensive. So if their blood pressure is low and that is way below their normal, they can also become altered mental status, because their brain's not perfusing like it needs to and like it normally does. And then we move into septic shock. As we get into severe sepsis, we're going to bolus them a bunch of fluids. We're going to flush the lactic acid out. We're going to help fill their tank, and we're going to give some antibiotics. If they don't respond to fluids, then we're into septic shock. And we need a vasopressor to actually constrict their blood vessels to help move all that blood, to help them perfuse all of the organs that don't get perfused. When we reach this severe organ dysfunction stage, it's not just like, oh, they're breathing fast and their heart rate's going fast. Their kidneys could start to fail. Their liver's not getting perfused. Kidneys, especially, are one of the things we look at when we talk about these things. A quarter of every single heartbeat goes just to your kidneys. So we think, oh, like all the blood needs to go to our brain and our heart and our lungs because those are all really important, and they are. But your kidneys are equally as important. A quarter of every heartbeat just goes to your kidneys alone. So we also look at kidney function here. But typically you're going to be looking at your lactic and your white blood cells. Because if your white blood cells keep going up, you're not treating something correctly. Because usually they're wide or broad spectrum antibiotics, meaning that this antibiotic has been shown to kill a variety of multi-organisms, but ideally you're going to give blood cultures to test those. So that's kind of the progression. They want to catch it at SIRS, but a lot of times you're going to pick up someone that's actually in shock. When we look at SIRS and SOFA criteria, the SIRS that your book is on the left, that's probably what you're going to be tested on. That's their definition of everything. So temp high or low. Normal sepsis, typically, you're going to have a high temp. They're going to have a fever. It's part of your inflammatory response, part of your immune system response. You can actually have cold sepsis, which is worse. Cold sepsis means that their body has become so overwhelmed that they aren't even able to maintain a fever. So instead of going high, they say, we're going to find a new low. Some of these patients, you will not be able to get a temperature on unless you get a rectal temp or a temp in their bladder. And that's more in the ICU. But that's how much their body decompensates and tries to protect itself, is that they're so tanked, they're so depleted that their body will actually become hypothermic. That's what cold sepsis is, and it's worse. Then you have your heart rate, respiratory rate. Those all come from trying to compensate, trying to still maintain some level of perfusion. The systolic can be less than 90. That's where all that leakage comes from. And then we already talked about mental status. The short, quick version, QSOFA. Are they altered? And it's not just altered, it's altered from their baseline. So some people will never have a normal baseline like we do, GCS of 15, oriented types 4. So if you're asking family, is this different than their normal? Same with kiddos. It's asking the parents, are they playing? Kid that doesn't play is a sick kid. Is the child acting normal? Has he been eating? Whenever a child goes backwards in terms of developmental milestones, something is also very wrong. If you have a little 6-year-old who mom's like, he's been potty trained since he's 2, he plays soccer every day, and she goes, he hasn't gotten out of bed for 3 days, he hasn't walked for 3 days, and all he does is wet himself. Not good signs. Try to rule out sepsis as well. And then, is the systolic less than 100? So I'm sure SIRS will be tested on. I'm not sure QSOFA, but in the real world, when someone comes in to the ER, we have all the tools in our mind of SIRS and sepsis, but clicking down, I'm looking at QSOFA first. Short and easy, but we also have to understand the patient that is getting brought in and the condition they're in and the history that we've gotten. I could have a trauma patient who's hemorrhaging, who's altered, whose respiratory rate's greater than 22, and whose systolic is less than 100. But they're a trauma patient and they're hemorrhaging. QSOFA is not going to tell you much if they're septic. So make sure you're using this in context to some sort of disease that you're suspecting they're infected with or some other cause. Again, we have all of these tools, but it's focusing the tools we need to that specific patient. Sound good? Distributive shock, there's 3 of them. We've talked about 2 today. It's anaphylactic, it's septic, and it's neurogenic. It's called distributive because when we have that increased capillary permeability, which is where all the leakage comes from, think of it as it's distributing all that fluid and energy somewhere else. They're all treated very differently. Neurogenic shock, you're actually typically going to see a low heart rate and a low blood pressure. Your heart rate isn't able to increase because you've lost sympathetic response, depending on the type of injury you have. But the anaphylactic and the septic, your heart rate's going to go up, blood pressure's going to go down, they're going to be altered. Try to treat the underlying cause. When we talk about shock, there's a lot of different kinds. Typically in test questions too, it'll be like, your patient is in obstructive shock. Is it a PE, an allergic reaction, or sepsis? You got to know which the different terminologies are because they're all treated different. But it is a distributive shock. Now, what are we going to do for it? We're going to do our ABCs. Someone can be so septic that they are not able to maintain their own airway. Their breathing's bad. And then, of course, if they're in septic shock, they're decompensating, their circulation is going to be poor. So that's where you might see your paramedic do your ABCs, and then they're going to start a line and immediately start fluids. They're going to help fill that tank, flush the lactic acid out, help move more through the body to increase that perfusion. So labs, blood cultures, and antibiotics. The labs we're going to look at white blood cells. Is there sign of end organ damage like kidney function? And then that lactic acid. Your lactic acid is one of the most specific lab values that specifically pertain to perfusion in the body. Blood cultures, so if you're in the ER, blood cultures get taken to try to rule in or out an organism to try to treat it. So you're going to do blood cultures, or they'll do blood cultures and then they'll do antibiotics. We don't do antibiotics first because we don't want to try to kill the bacteria before we're able to catch it. So if I push a bunch of antibiotics, it's going to start affecting that bacteria. I'm just going to pull an empty blood culture out. So that's why cultures before antibiotics, if you see that in the ER. And then the antibiotics, again, are broad spectrum to begin with. And then those get all kind of cool lab stuff. But antibiotics is key here. Standard for nurses is within 6 hours, typically, from when you have known sepsis. Other places are like 2 to 4. Pretty intense. Vasopressors, that's going to be your norepi, vasopressin, and epi. Try to shunt all the blood basically to the important organs to increase perfusion. And then it's just supportive care after that, making sure they have good nutrition, watching them, seeing what they want to do. But sepsis is huge. Please never forget about sepsis. Alrighty, we want to break before we finish the case study presentation. Okay, so I'll let you meet with your groups, 5-10 minutes or so, see if there's anything you want to change about it, and then we'll go through them. Does that sound fair? Cool. There's your prompts if you forgot them. Answer. It's to get into the mindset of how this is classroom, this is lecture. You're not touching patients, you're learning all these things. But you have to be able to take everything that you're learning and apply it in the real world for real patients. And a lot of times too, I find in the classroom you get tunnel vision. Like, oh my gosh, we're only talking about anaphylaxis. And then you have a patient whose blood pressure is low with facial swelling. Is it anaphylaxis? There may not be. So we're all going to